Aloha and welcome to this special presentation, Measles 2025 Update, What Hawaii Clinicians Need to Know. My name is Mark Alexander, Executive Director of the Hawaii Medical Association. It is my pleasure to welcome you this evening. This evening's presentation is being sponsored by the Hawaii State Department of Health, the Hawai'i Chapter of the American Academy of Pediatrics, the Hawaii Academy of Family Physicians, and HMA. It is my pleasure now to introduce the facilitator for this evening's session, Dr. Nadine Tenn Salle, Clinical Chief of Pediatrics of the Queen's Health System. Dr. Tenn Salle.
Hello and good evening, everyone. My name is Nadine Tenn Salle, and as Mark mentioned, I'm the Queen's Health System Clinical Chief of Pediatrics. Thank you for taking the time to join us this evening for what we believe will be a timely and essential conversation. As of today, Hawaii has one confirmed case of measles. So let me be clear, this is a case, not an epidemic. That distinction matters. It means we have a unique opportunity, an opportunity to clarify facts, to strengthen our collective clinical response, and to better understand the partnership we as clinicians must have with the Department of Health to prevent an outbreak if we can, and prepare for one if we must. We will not be discussing tonight anything about vaccine refusals, but what we will discuss is the reality that there are certain school districts in Hawaii, particularly in Maui, where the MMR vaccination rates have dropped to as low as 34%. That level of vulnerability puts entire communities at risk, and measles, unlike many infections, is unforgiving. It's one of the most contagious diseases known, with an R naught significantly higher than COVID-19 or the flu. And managing measles is in many ways so much more complex than what we as a state and the nation experience with COVID. This evening, we're gathered an incredible panel. It's a panel of experts that include both public health as well as clinical practice to walk us through what every Hawaii-based provider should know. And the discussion will be divided into 5 main sections. The first will be the clinical background and transmission, MMR vaccination and immunity, response to suspected cases, case investigation, isolation, and post-exposure prophylaxis. And finally, we'll talk about the resources and next steps and allow for question and answers. Our goal tonight is to ensure that you leave with not only a clear clinical guidance, but also with a practical sense of how we can work together across the system, across the island, to keep our communities safe. With that, I'm honored to introduce our panelists. We have Dr. Sarah Kemble, our state epidemiologist for the Hawaii Department of Health and the Chief of Disease Outbreak Control Division. We have Dr. Jennifer Mbuthia, Allergist and Immunologist, practicing both at Kaiser as well as Queens. We have Dr. Nathan Tenn, the Deputy State Epidemiologist for the Hawaii State Department of Health and the Deputy Chief of the Disease Outbreak Control Division. So Sarah, let's begin with you. Let's start with the basics. What does measles look like and who's it most?
Yeah, so I wanted to talk first tonight about what the measles presentation is. Many of us have never seen a case of measles up close and personal. That's thanks to having a vaccine that really works well. But let's step back then and say, what does measles look like? It is a highly contagious respiratory infection caused by a virus, and it's transmitted by direct contact or infectious droplets, so primarily airborne transmission. The symptoms of measles include fever, and then runny nose, cough, red eyes, sore throat, which is the classic 3 C's that we all learn in medical training: cough, coryza, and conjunctivitis. This is followed by a rash that will develop a couple days after those initial symptoms. Starts on the face and spreads down and out to the rest of the body. Unlike some other childhood rash illnesses, children and adults with measles are often uncomfortable and feel quite sick. Next slide, please. Oh, I have, sorry. Forgot. So one of the things that we have at the health department is experience with cases that have been reported to us over the years. So this is one photo series from our DOH case series that I wanted to share because it shows a really clear progression of the classic measles rash. The classic measles rash starts on the face, often involving also behind the ears and over the eyelids. And it then spreads centrally downwards and then outwards. So it'll go generally head, face, down to neck, trunk, and then out to extremities and including the lower extremities. This is the classic morbilliform or maculopapular rash. Morbilliform actually means measles-like rash, so this defines morbilliform. Early on, so you'll see like day 0 where the rash is a little more faint. This can be a blanching rash, but it will then progress to non-blanching. So when you see the day 2 pictures here, there's 2 of them taken on day 2. That's the really brick red, bright rash that at this point is likely non-blanching in some areas. And then as you see, as the rash begins to resolve, it'll darken and become non-blanching. That's day 5, and now it's spread downwards, and we really have more involvement of the trunk. And then day 6 is where you're seeing that rash start to fade. Usually the rash is gone by day 7. So that's really our classic measles rash. We get a lot of questions about Koplik spots, and we're taught in medical school that Koplik spots are pathognomonic for measles. The problem is they're really hard to correctly identify. So Koplik spots are blue-white spots with a red halo. So the central part is actually pale and the outer rim is red. They appear on the buccal mucous membrane opposite the premolar teeth 24 to 40 hours before the rash, and usually resolve within 2 to 4 days. Why do we worry about measles? Measles is a serious illness. 1 out of 5 unvaccinated persons with measles are hospitalized. 1 out of 20 children with measles develop pneumonia. 1 out of 1,000 develop encephalitis, including possible lifelong deafness or intellectual disability. 1 to 3 out of 1,000 will die. And during pregnancy, measles can result in pregnancy loss, prematurity, or low birth weight. So we're talking about a serious condition here. This slide is mainly to walk through why the timing of symptom progression is important, and then to segue us into talking a little bit about testing. So it's a lot going on in the slide, but just to walk through it, at the top we have the fever curve, which may start as low grade, but measles fever is classically high. It can get to be as high as 104 Fahrenheit. And that fever is usually peaking about the day that the rash appears. The cough can start on day -3 before the rash, 2 to 3 days before rash. Coryza, runny nose, 2 to 3 days before. Conjunctivitis, likewise. And those Koplik spots, if you see them, are probably going to be 1 to 2 days before rash onset when they first appear. And the day the rash starts is considered day 0. Why is this important? Well, everything we talk about measles is in relation to the day the rash started, not the initial symptom onset, but the day the rash started. Rash is day 0. Measles is considered infectious from 4 days before rash onset to 4 days after rash onset. And what do you need to know for testing? If you look here, you'll see in the old days when they did viral cultures, that's how we know when measles is most infectious. There's 4 days before and 4 days after. But these days, we're primarily doing either PCR or serology. And the PCR is your best test in the first few days after rash. And then serology may become useful as starting maybe 3, 4, 5 days after rash and thereafter. There's a lot of illnesses that look similar to measles. And some of this can be hard to sort out, but really thinking about your local patterns and epidemiology. Roseola is a classic measles lookalike, where you have that brick red rash just like measles. The big difference there is by the time the rash appears, usually the fever's gone. So that classically, you have a kid fever, fever, fever. The next day, fever's gone, rash appears. That's roseola. Measles, fever, and rash come together. Enterovirus, maybe seasonal flus, being more in the summer. Rubella can look similar, but is much milder, and we don't see a lot of that these days. Scarlet fever is often a very confluent rash, and you'll have other signs of bacterial infection. Adenovirus can occur without a rash, but can sometimes be a mimic for measles. Kawasaki rash is even more prolonged than measles. And then drug-induced rash is another consideration, but you would get that. So a little bit more on testing, just to revisit this and make sure to really address this. There's first the question of who should you test? So definitely think about this presentation, the timing of symptoms and rash. Individuals with fever and a classic measles rash, those other signs and symptoms like cough, rise of conjunctivitis, should be tested regardless of what else is going on. If you think this really fits the pattern of measles, we would like to get that tested. Also, individuals who've had a known measles exposure, and so, for example, they're in a high-risk setting during the likely exposure period, 7 to 21 days before the rash, and they have a fever and rash, those are people who should be tested because of their exposure, even if you don't think it's totally classic. All other situations require some clinical judgment. So if you're thinking of testing for a suspect case without classic measles symptoms and no known exposure, this may depend on other things. Is there measles transmitting widespread in the community? In Hawaii right now, there is not. That situation could change. And so we would be sending out notifications if that changed. But as of now, we are really focused on the specific exposure settings that we have identified. It might depend on whether the suspected case potentially exposed a lot of other people. Did they go to visit a NICU the day before? That might be a reason to test in and of itself because of the consequences if we miss a case. And then anyone who's had international travel, and at this point, travel to certain areas of the United States where we know there are active outbreaks, would also be a lower threshold to test. But the main point here is if you order a test, be sure you are instructing the patient to isolate while you wait for test results. If you do make the decision to test, that comes with the whole package. It's not a wait and see, maybe the IgM will come back in 5 days and then we'll know. In those 5 days, you need to be notifying public health, you need to be instructing them to stay home and not go to school or work, and all those things go together with it. There are 2 main test types that you can order for measles. One is the RT-PCR. The best specimen to collect for RT-PCR is a nasopharyngeal or oropharyngeal swab. For infants and toddlers, they may tolerate the oropharyngeal swab better. This is going to be the most sensitive test you can do within 3 days of rash onset. It can also be positive up to 10 days after rash onset. Urine's another specimen that can be tested for PCR and may remain positive for a little longer. So this might be a good test to consider if you're already at day 5 after rash or further out, and you want to get extra insurance to try to look for potential measles. Serology is for antibody testing. This is and just to clarify, PCR is run at the state laboratories division. We are the only place you can get an RT-PCR in the state, so do contact Department of Health right away to coordinate RT-PCR testing. For serology, this can be ordered commercially. It's not performed at DOH. And you order a measles-specific IgM antibody test when you suspect a case. It's going to be more likely to be positive after 3 or 4 days after symptom onset, and most likely to be positive past 5 days, and it can stay positive for up to 6 to 8 weeks after acute measles. IgG can also be used to test for immunity and occasionally for diagnosis of acute measles, but really the PCR and IgM are going to be your preferred test for acute measles. One caveat to note is that people who had vaccine, who had MMR 6 to 45 days before their rash onset, may still have positive titers from the vaccine. And so it can be very tricky to sort out wild type measles from an IgM that's positive from the vaccine that was recently given. In these situations, please consult with Department of Health and we will help you work through any other testing options or how to make that assessment of whether to treat that as a case. Just a reminder that PCR is preferred. and that you should call Hawaii Department of Health immediately if you suspect measles. We can advise you on the best testing options based on the clinical scenario. We can coordinate submission of your specimens to state laboratories, and we can confirm isolation recommendations and initiate contact tracing and prophylaxis. These are our reporting line phone numbers. This will be recorded and the slides will be distributed, but please make note of these and have them pinned up on your office boards. Just a few notes about epidemiology before I pass it on to Dr. Mbuthia. This curve, the main takeaway here is, look, it was peaking. We were talking about 500,000 cases a year back in the 1960s, and it has been nearly flat since 1993. Why is that? It's the introduction of vaccine. This vaccine, as I said, it works. So 2 doses of MMR, 97% effective. You're going to hear more about this from my colleague, but that's why you've seen a flat curve for all these years. But measles outbreaks remain a risk today. Worldwide, there were an estimated 10.3 million cases of measles in 2023. That's a 20% increase from 2022. Additionally, measles vaccine coverage in the US and many countries overseas have been declining. And this is often due to widespread disinformation. Since 2000, measles cases in the US have been associated with recent international travel among unvaccinated persons and, and outbreaks in the US among undervaccinated individuals. This is just drilling down on the very recent part of that epi curve. And this is 2000 up to present. And so even though it looked flat in that big picture compared to the 1960s, what we're seeing recently, just pre-pandemic, so starting in 2014, we had a little bump in cases to over 600 that year throughout the US. 2019, we got to over 1,200 cases throughout the US. 2024 was looking a little high again, even though we had a dip during the pandemic. 2025, this chart was created back in January, so it looks like it's really low, but that's not true. So 2025, as of today, we're at about 720 cases nationally in 25 states. And so we're exceeding 2024 levels and even 2014 levels. And for this early in the year, we're pacing to exceed 2019. We nearly lost elimination status in 2019, so that is a concern this year as well. We typically see 0 to 2 imported cases per year in Hawaii. Did have a larger cluster back in 2014, but with recent declines in 2-dose MMR coverage, our risk for outbreaks is increasing in communities with less than 95% coverage. At Hawaii, statewide, our entering kindergarten MMR coverage rate was just about 90%. In some specific islands, it may be even lower than that. And with that, I'm gonna.
No, let's transition. Let's transition to MMR vaccines and immunity. And Jen, why don't you do what you do best? Bring clarity to this.
All right, so just proof that great minds think alike. Here's some data. This is actually 2022 to 2023 kindergartners entering school, and it's very humbling to see the low rate of MMR vaccination among our kindergartners. So some basics about the MMR vaccine. It's available in 2 different formulations, measles, mumps, rubella, or MMR, and there's also measles, mumps, rubella, and varicella, MMRV. I will mostly just say MMR just for the ease of communication, but both of these contain live attenuated viruses. There is no single antigen measles vaccine available in the United States. So if patients are asking and they just say, I don't want the MMR, I just want the measles component, that is not manufactured or available in the US. A little caveat for my pediatric colleagues who do administer MMRV, the spacing interval for that is 3 months between doses, while the spacing interval for MMR is 28 days apart. If an MMRV is given 28 days apart, that is still considered valid, so you don't need to do a 3rd revaccination at the 3-month mark. 1 dose of MMR vaccine provides about 93% protection from measles. 2 doses that are adequately spaced 28 days apart or longer then provides about 97% protection. This is a very effective vaccine when it comes to measles prevention and protection. And I also get asked, from the time of that first vaccination dose, when is someone actually considered protected from measles? Usually takes about 2 weeks from the timing of the first dose for the person to have protective immunity titers. Although the evidence of the vaccine working is seen within a matter of days, that protective titers is reached in about 2 weeks. Now this chart, I'm not going to walk you through every single block, but what I really wanted to do was put something together that could be a single slide reference across the age spectrum for all clinicians. So on the far left column, I either talk about age-specific criteria or something specific to the circumstance of the patient, such as work or travel. In the middle, that column talks about what the standard recommendations are. This is what we should be following right now. The far right talks about measles outbreak specific recommendations. And as a reminder, we are not currently in a measles outbreak, but I wanted to have everything available on one slide for reference. So anybody who was born before 1957, it is assumed that you are immune from having actually had measles during your childhood. So anybody born before 1957 who inquires, they probably have never had an MMR vaccine if they don't work in healthcare or do international travel, but it's presumed immunity. Anyone born 1957 or later should have received at least 1 dose of an MMR vaccine in their lifetime. If we do get to a point of a measles outbreak, then that person, if they've only had 1 dose, they should get a second dose as long as it's been at least 28 days. Infants between the ages of 6 and 11 months, there is no routine vaccination with MMR. And the reason behind that is because there is still some maternal antibody that can actually inactivate the measles component of that vaccine. However, during an outbreak or high risk for exposure, infants between the ages of 6 to 11 months can receive a single dose of MMR vaccine before their first birthday. I often will refer to that as the 0 dose because it does not count towards the 2-dose series, which they can then receive once they turn 12 months. That first dose of that series, though, would have to wait 28 days from when they got the 0 dose. For kids 12 to 6 years old, this is where most of our pediatric population and school-age children will fall. They got 1 dose when they were 12 to 15 months, second dose between the ages of 4 and 6 years old. If a child did receive their second dose before their 4th birthday, it does still count as long as it was 28 days from the first dose. If a patient tells you that they were clinically diagnosed with measles, we do not rely on just a clinical diagnosis. There would need to be laboratory evidence of a measles infection. For my colleagues who work in healthcare, you probably have received either 2 doses of an MMR vaccine and/or you have had titers done because you work in a healthcare setting. So those don't change from standard to outbreak recommendations. And then anybody who's looking at international travel or travel to a high-risk area, which could include mainland USA, it is recommended that there are 2 doses of MMR vaccine on board or a positive measles titer. So some special considerations for vaccination. There was a window of time in the US where a single antigen measles vaccine was administered, and it was an inactive or killed vaccine. What was found is that that measles vaccine was not very effective in terms of long-term protection. So there are some adults who you may know or work with who were born between 1963 and 1967 who got that single antigen inactive measles vaccine, and they should just receive a dose of MMR, or you can offer to get titers if they're unsure. A lot of people who were born in the times before electronic medical records, such as myself, don't know where their medical vaccination records are from childhood. And so it is really common. People don't know which they would have received. It's also important to keep in mind that if somebody receives blood products, that oftentimes will have some antibody contained within it. This includes immunoglobulin like IVIG or IMIG, which I'll talk about later. It also includes things like whole blood or packed red cells. Depending on the blood product that they receive, you have to wait between 3 to 11 months before they receive the MMR vaccine. This is because even a small amount of measles antibody in that product can interfere with the live attenuated virus replicating and initiating a good immune response. So that is why there's that wait period. And as I've already mentioned, infants between 6 and 11 months, that is a 0 dose because there might be inactivation due to maternal antibody circulation. So what are some true medical contraindications to giving someone an MMR vaccine? First and foremost, because it is a live vaccine, severe immunocompromising conditions, and I list some of them here, are reasons to not give an MMR vaccine. Also, if there is a history, family history that's suggestive of a primary immunodeficiency, then you would not administer any live vaccines to that patient until you have laboratory testing to demonstrate that they have immunocompetence. Some patients are actually immunosuppressed because of different medications. Pregnancy, although it's not an immunocompromising condition, due to the theoretical risk of that live virus having some impact on the developing fetus, pregnancy is a contraindication to live vaccines. Also, anybody with a history of a severe allergic reaction, and as an allergist, when I say that, I mean the patient has had anaphylaxis to either MMR or to a component of MMR. And the allergenic elements of the MMR vaccine are gelatin and neomycin. There once upon a time was some urban myth that if you have an egg allergy or penicillin allergy that you cannot receive MMR vaccination. These are not true and they are not contraindications. So anybody with an egg allergy or penicillin allergy label can still safely receive MMR vaccination. A little bit more detail about immunocompromised individuals and MMR vaccine. So there are guidelines for certain types of clinical immunodeficient or immunosuppressed patients. Two of the ones that I most often get asked about, I've listed here. So HIV positive patients who have either their total CD4 count is 200 or greater, or their CD4 percentage is greater than 15%, can still receive MMR vaccination because their CD4 T helper T cells could still mount a good response, and they should, in fact, receive MMR vaccination if they haven't been vaccinated already. Also, I get asked a lot of questions about people who are on steroids. So high dose systemic steroids would be 2 milligrams per kilogram per day or 20 milligrams per day of prednisone for 14 days or more. 14 days, 2 weeks of steroids can be enough to suppress the immune system to then make it difficult to mount a good response to the vaccine. So you would want to wait a month after finishing that high dose or prolonged steroid course. Topical, ocular, intraarticular injections are not a risk for immune suppression. So patients who are on these routes, many of my patients are on inhaled corticosteroids, not immunosuppressive, they can still receive MMR vaccination. Some patients can get restored immune competence and immune function after something like chemotherapy or some immunosuppressive drugs or immunosuppressive biologic medications. So usually the mark that we use is about 3 months from last dose, but this should always be discussed with the specialist who is prescribing it. And luckily the CDC does still have an active webpage about vaccines and altered immune competence. There's a link there, and I did verify it before putting it in the slide deck just to make sure that I'm not directing you to an invalid webpage. So some MMR vaccine precautions: moderate or severe acute illness, anybody with a history of thrombocytopenia, receipt of another live vaccine within the preceding 4 weeks would be considered a precaution because you don't want 2 live vaccines within less than 4 weeks of each other. Also, if somebody needs to get a tuberculin skin test or interferon gamma release assay, within 4 weeks, ideally you would administer on the same day as you're giving MMR vaccine. And this is just vaccine spacing basics. A little bit about the vaccine and pregnancy. So pregnancy is a contraindication to MMR vaccine. However, if a patient is discovered to be pregnant after recent receipt of an MMR vaccine, there's no reason for termination of that pregnancy. There are centralized registries to follow the patient, but oftentimes reassurance is the biggest thing that you can offer as a clinician. I also wanted to say that a positive rubella titer in a pregnant patient, which is often part of that routine panel for pregnancy, is not considered evidence of measles immunity. And that's because you only need 1 dose of an MMR vaccine to reach protective rubella titers, but 2 doses are what is required for the measles and the mumps component. So even though there might be a positive rubella titer, please do not assume that that same patient is immune to measles. A little bit about vaccine and vaccine side effects, safety. So the common things with vaccines that we anticipate that are considered benign side effects, things like fever, pain, and swelling at the injection site, are the most common things that we see. MMR vaccine, for the most part, is very safe and very highly effective. Children who have a history of febrile seizures may be at increased risk for having a febrile seizure following vaccination. This is a precaution and not a contraindication. Also, as Dr. Kemble had mentioned, there is a rash that can appear in patients about 7 to 10 days after receipt of MMR vaccine. Happens about 5% of the time. This rash is not contagious, but as you can imagine, it can and might be confused with actual measles infection itself. So please contact the Department of Health if you have a circumstance where a patient had an exposure, got the vaccine as post-exposure prophylaxis, and now has a low-grade fever and a rash. There are several other clinical cues that can be important, so you're not alone if you do run into that situation. Thrombocytopenia, as I mentioned before, is something that has been seen in patients with following receipt of MMR vaccination. Usually it appears 2 months after vaccination. It is self-limited, and it is more common in patients with a history of thrombocytopenia. So if you have a patient with this history, you want to have a risk-benefit conversation with them, and then consider monitoring their platelet count for about 60 days after vaccination. Also, arthralgia is reported. This is actually thought to be due to the rubella component. Most often it is seen in adult patients, usually female, about 25% of the time. Again, as an allergist, anaphylaxis is always what I like to look for. It is very rare, about 8 to 14 cases per million doses given. So it is a very rare issue and a very rare safety issue, but that can happen with any vaccine. Just be prepared to recognize the signs and symptoms and treat. A little bit more about measles serology. So lab evidence of immunity is based on IgG detection. Lab evidence of infection, it utilizes IgM detection. So anybody who has had a negative or equivocal measles IgG test, maybe for employment or before going to college, then you should receive at least 1 dose of an MMR vaccine, and there's no need to recheck titers after immunization. A key point about IgM testing, if you suspect a measles case, I do want to add the caveat that it can be negative for up to 3 to 4 days after symptom onset, because the body has to make the IgM. So there is a risk for false negatives. That is why the RT-PCR is so important in diagnosis. And then a little bit of detail about post-exposure prophylaxis. So from the time of exposure and immunization, those are the key factors in deciding who really should at all receive post-exposure prophylaxis. What kind of exposure did you have, and what's your immunization status? Now, immunoglobulin preparations are pooled IgG from thousands and thousands of blood donors, and it contains adequate levels of IgG for protection from measles. There's 2 formulations that apply in the situation for measles PEP. One is intramuscular Ig or IMIG. Now the maximum dose is 15 mLs. So that means that for patients who weigh more than 30 kilograms or 66 pounds, 15 mLs is not likely to provide a protective antibody level. Therefore, the IMIG really only pertains to our pediatric population, because that is usually where you are seeing patients under 30 kilograms. That means that intravenous Ig or IVIG is an option for vulnerable populations, 66 pounds and greater, so most of your adult patients. A precaution should always be had in patients who have IgA deficiency. And please keep in mind, immunoglobulin is passive temporary immune protection. It does not replace long-term immunity from an MMR vaccination. However, if a patient does receive an immunoglobulin preparation, they have to wait several months before they can get an MMR vaccination. Again, that depends on the route and the product that's used. I put together a chart that kind of summarizes, again, time from exposure and then risk factors in patients and what the formulation would be in terms of post-exposure prophylaxis. So this is a single slide. All the slides are going to be available to everyone who's registered for this webinar, but I wanted to put something together that you could hang in your clinic. But nobody should be administering post-exposure prophylaxis without first consulting the Department of Health to identify, does your patient meet the qualifications, and then to coordinate how that administration is going to happen. A little bit, I think this is my last slide talking about vitamin A and measles, because this has come up as a bit of a controversial item. So vitamin A does not prevent measles. The only way to prevent measles is with vaccination. Vitamin A is also not treatment for measles infection. There is no treatment for a measles infection. There is supportive care. Vitamin A can, however, reduce mortality from measles infection in patients who are severely malnourished, especially with a vitamin A deficiency. Now, in the United States, most children in the US do get enough vitamin A in their diet. Another thing about vitamin A, because it's not water soluble, so you don't just pee it out if you have too much, vitamin A can be toxic if dosed too high. So there are some very specific recommendations for who should receive vitamin A. It should always be under the direction of the clinician who is managing and aware of what the proper dosing is for that patient. But again, the best way to prevent a measles infection is through vaccination. And with that, I'm going to pass it over to my colleague, Dr.
But
Tenn.
hold on one second, you can pass.
Okay.
Dr. Tenn, we're going to talk about the initial clinical response with respect to cases. We did have a couple of quick questions, and I thought, since they're really on what you guys just went over. One of the first ones, you did a slide, again, trying to distinguish where we are versus pandemic. But one question was, you're born before 1957. What are the advantages and disadvantages of the patient just asking to get an vaccine versus maybe the advice?
So that's an excellent question. Now, if someone is going to be working in a healthcare setting or having international travel, then honestly, either one will be accepted, but a lot of times a school would like to have proof of immunity with a titer. If a patient would just like to get an MMR dose, there is no harm in administering an MMR vaccine to somebody who already has immune protection from either previous vaccination or from previous infection. It's not dangerous at all as long as they don't have any of the contraindicating conditions. Some of the things are that you can give the MMR vaccine and then the patient can go on about their business and they don't have to follow up or do another visit. So there is that benefit. The MMR titer or measles titer does take a few days for the results to come back. And if negative, then the patient would have to come back to the clinic. So a lot of it is going to be based on the logistics and the cost. But to receive an MMR vaccine, if you are already measles immune, that is not a harmful situation.
Okay. And number 2 of 3 questions I'm going to sneak in. The second question was understanding the recommendations for the PCR. They were asking, why not just do an IgM, IgG instead of PCR?
So in the first about 3 to 5 days after rash onset, you may not see any positive titer. So serology may not diagnose measles in that early phase. So in the first few days, rash onset and thereafter, you really want to get that nasopharyngeal swab or oral swab for PCR as the most sensitive diagnostic test. And time's of the essence, why not just wait and do the serology later? If you have a patient who happens to have isolated the entire time, 4 days before their rash until then, that might be an acceptable plan, but most of the time people have gone somewhere, they've gone to the grocery store, they've been to daycare. And so all of those exposures are really critical for us to know that that's a measles case and be able to react in a timely way, because people who may be at risk and need to get immunoglobulin, need to get MMR as PEP, they only have a few days to make that window. So it's so important to diagnose her.
Last question, and then I'll turn it over to you. It's actually 3 or 4 questions, but in the end, I think what people are referring to is the second MMR.
Well, we're not in a formal space as in an epidemic to say we're going to ask everyone to do it. I think most are asking, is there harm? So typically toddlers get it at the 12-month. The next one will be at 4 years old. You shared that you can give it within 28 days unless you give the MMV, which is in 3 months, if I'm correct. And the question is, can they just elect to give the second MMR? That's number one. And then number two, is there any harm to it? There's an expectation that they now don't have to give it at 4 years. Comments?
So what's interesting, when I look back through the history of the measles vaccine, part of the reason why there's that 4 to 6 year old recommendation is because most children started kindergarten at that time. So the second dose was to really boost their immune system before they entered school and had a lot of exposure to other children. But if a parent is asking to get that dose, that second dose, before that 4 to 6 year window, because of, again, travel or just their general concern or anticipated travel this summer, then go ahead and give it. It counts. There's evidence that measles vaccine-induced immunity lasts several decades. And so it's better to err on the side of caution if there are parents who are very concerned and because of their child's exposure risk or planned family risk that they want to receive it early. I would rather families who are embracing vaccines feel comfortable and confident before they go into a high-risk exposure situation, rather than feel as if their concern was maybe not heard, even though they voiced a desire to receive the vaccine.
Thank you. I'm going to talk a little bit about responding or thinking or preparing for measles in the healthcare clinic. And if you're seeing patients, maybe some things you might start to think about. And hopefully make it real simple and kind of focus on some things. So I think the first thing is to understand, just to reiterate, measles is highly contagious. 9 people out of 10 who are unprotected are in close contact with an infected person will develop measles. And that potential, it's also airborne. It'll remain in the air and on surfaces in an area where a person has been for up to 2 hours. So highly contagious. That's the first thing I think you should remember as a clinician when you're thinking about or assessing somebody who might have measles. And in terms of thinking about exposure that can happen in a healthcare setting, measles exposure, in terms of what we consider exposure, it's spending any amount of time while having unprotected exposure to a person who is infectious with measles in a shared airspace with an infected patient, or being in that room for up to 2 hours after. So it's just any time if you're not using any protection and you don't have any protection at all. It's regardless of your immune status. I think those are important things to remember going into evaluating a patient. So those shared airspaces, common things that we really worry about would be like a waiting room. Somebody's waiting out there, they got a fever and a rash, they got measles, they're sitting there. That's a really bad situation. Okay. Those shared spaces can include like a emergency room department, a large one, if there's a common air handling system that doesn't have any air filtration too as well. So really that's important to think about when you have a procedure in place to deal with people that could have measles. You really want to think about controlling the contagion, preventing that spread. Really, that's the first thing to think about. Not the complex spots, but controlling the potential for spread. So things that you should be thinking about now, to take now. I think the first thing is just to remember that everything that's been stated up here, we have effective vaccinations. So if the only thing you do right now for your clinic is to ensure that everybody has immunity, presumptive immunity, and you have written documentation, you're going to do great things for your staff. So the first thing to do is make sure everybody has some form of immunity and protection. We have great tools for that. The next thing I would say is to start teaching your staff about measles, because there's probably a lot of anxiety. We're hearing a lot about it in the news. You know, it's serious, it's highly contagious, but we can prevent it. And we see a lot of things in the clinic can look like measles. And you know, what is measles? What should we do about it? So talk to your staff, start educating them. So next would be like what to do when somebody comes in with measles. First is to start to identify, think about the scenario. Somebody with a fever and a rash, maybe start to think about it and start to think about controlling the contagion. Put a face mask on that person, provide them a face mask, and start to think about separating. If they're already there, start to separate them out. Put them into an airborne isolation room if you can, if you have that available. If you don't, put them into a private room and close that door. Airborne isolation, really important to get started early. Have a procedure in place too as well. Somebody calls in, you know, they think they might have measles, they've been exposed, they're ill, or they have something that is consistent with measles. Think about triaging them, gathering that information on the phone, or maybe even meeting them outside in the parking lot, someplace where they're going to be away. So controlling that contagion, that's really first step. Okay. And again, if you're starting to think about it or suspecting it, airborne precautions, standard and airborne precaution, get them started early on that. Isolate the patient, and then if you're going to be evaluating that patient, make sure you're putting on an N95, a well-fitting N95 or higher face mask. So, you know, measles, clearly causes anxiety when we have a case that comes in and presents like that. It's kind of like running a code, right? We get anxiety. This is a flow sheet that can be used in the bedside to help you kind of navigate that. Things to think about when you're evaluating a case would be to do what you normally do as a clinician. Gather the clinical history. What are the symptoms? What are the characteristics of those symptoms? Fever, rash, learn more about that. Is that rash vesicular? If it's vesicular, it's not likely to be measles. Measles is not a vesicular rash, okay? The next thing to think about is exposure. So thinking about exposure, epidemiologic exposure, have they traveled in the last 21 days? Have they traveled domestically, anywhere where there is active measles transmission or an outbreak? Or are they reporting exposure to somebody who actually has measles? If somebody is coming to your clinic and telling you, I was exposed to somebody who was infectious with measles, that should raise a red flag for you. That is someone you really should be suspecting, and that would drop you down to measles exposure. But start gathering information. You know, is it classic for measles? Okay. Were they recently vaccinated? If they have no exposure, if it's classic, but they recently received a measles vaccine, it is probably a measles reaction to a measles vaccination. Okay. And then ask about prior vaccination. Measles vaccination is highly protective. If they've had measles vaccination, 1 or 2 doses in the past, it's pretty unlikely that it is measles. However, it could still be suspected. Okay, so this kind of helps guide you. It is not to overrule your clinical suspicion. So if you still have clinical suspicions, you should be giving us a call on the disease reporting line and arranging and discussing the case and thinking about ensuring that their patient is isolated and thinking about getting testing to confirm if they have measles. These are slides that you can use. I'm going to go through. I'm not going to go through these, but in the slide deck, you could use this as educating your staff. Just to go back, that flow diagram really pertains to the situation where we have no local measles transmission in the current state that we're in right now. We talked about airborne precaution. Excuse me. Right way. Here we go. Sarah covered this in terms of measles presentation. You can go over your staff with that. Other conditions, again, covered really nicely by Dr. Kemble. But again, a nice tool to use with your staff to go over with them as well. Testing recommendations, just to reiterate, collect nasal pharyngeal, oropharyngeal swab for measles. We at State Lab, we required a Dacron synthetic tick swab, and you place it into a viral transport medium. But call us and we can talk you through that too as well. We're coordinating the testing with State Lab, with the Hawaii Department of Health. And then also obtain serology for measles, IgM, IgG. So in terms of just managing exposures to measles in the healthcare setting, again, this goes back to the vaccine being highly protective. Those with presumptive evidence of immunity, post-exposure prophylaxis is not necessary. Work restrictions are not necessary. However, those that are exposed, so like if you did not put on that N95, the clinic should be monitoring, making sure that that healthcare worker is not coming in and having symptoms and taking care of patients. So start to implement monitoring day 5 through 21. And then I believe this is the last slide. Those without presumptive evidence immunity start to really think about the post-exposure prophylaxis if it's within that window. This is really important. They need to be excluded from work day 5 through 21 after their last exposure. And that would be if that case was infectious, 4 days before the rash onset and 4 days after, okay? And then if the healthcare personnel received only 1 dose, but they didn't have 2, work restrictions are not necessary, okay? But they should receive the second dose as soon as possible, at least 28 days after the first dose. And then again, implement the daily monitoring, making sure they're not reporting to work with fever, cough, conjunctivitis, coryza, those kind of things, rash too as well. Okay. That's it.
I'm going to shift gears. Thank you very much. There's approximately 50 questions here, so I'm going to try to group, and I'm going to throw it out to the group, and you take it as well. There was someone mentioned that at least my voice is cutting in and out, so can we play that game? I tell you the question, kind of paraphrase the question back, just in case my voice falls out. Some of it to the point of titers and the clinical team. Let's just focus there for a second. There were a lot of questions of whether or not all healthcare providers should go back and redo their titers. A lot of the questions seem to be around how long, like if I already knew I had a positive titer in the past, and assuming I haven't gone through any sort of chemotherapy, can I just call it a day, or should we be doing it again? That was the first. And then there were a number of clinicians in the community, I think maybe asking both for themselves as also as they begin to start to write for this, is this a covered benefit? Both getting the maybe an additional vaccine outside the childhood period, as well as ordering times.
So I think something to keep in mind is that if at some point in time you had a positive measles IgG titer, let's say you were starting a job, going to college, joining the military, unless you undergo some sort of either immunosuppressive therapy or potentially if you have a very, very, very high risk exposure, maybe you're working in a clinic that is seeing a lot of patients, there is not a reason to then go back. The IgG level is an indirect way to show that you have immune memory. So as long as your immune system remains competent, that memory lasts. Could you, as you have waning titers, could you get a case of measles? Yes, but we also know that in those patients who get measles several decades after they completed an MMR series, the symptoms are very mild because, again, it doesn't take much to remind the immune system. That aligns with usually a question that people ask, well, do I need to get a booster? There's not an indication for MMR boosters. So we are not dealing with a vaccine such as tetanus or COVID or flu where booster dosing is indicated. This is a live attenuated vaccine, and live vaccines work very well at stimulating the immune system and creating pretty long lasting immune memory. So a routine booster is not indicated. But at the same time, if someone has no records of vaccination and would like to receive an MMR shot, that is still considered safe as long as they don't meet any of the routine contraindications.
Leaving
can-
outside, go ahead.
I'm going to add, so if a healthcare worker has 2 documented doses and it's adequate documentation that they've received the MMR vaccination, that's considered adequate level for presumptive immunity. If that person went on and got an IgG test and it came back negative, we would not recommend, it's not recommended that they get another MMR vaccine. It's not.
That was the next question, whether or not they should go and get the second, do the series one more time. So the answer is no to that.
So I think in certain settings, like let's say employment or schooling, I have run across situations where the titers were what was required, and the school then requires 1 dose. So we're not dealing with the hepatitis B non-responders where you repeat the whole series.
Right.
It is 1 dose if required, and then you don't need to recheck again. And that's only if that facility or institution requires titers and it was negative or equivocal inconclusive. 1 dose MMR and you don't repeat titers after.
We do find it is occupational health dependent, and there isn't really a wrong answer there, but we have encountered someone got their 2 doses of MMR documented, had a low titer, got a 3rd dose, and then the titer was repeated. We wouldn't recommend getting into that game of cat and mouse. That 3rd dose should be where it ends, and that's enough.
There's an emergency room doctor. He practices at HBMC. He's concerned about the response once. So there's a case in the community. It spreads into the community, local clinics, PCPs and others. They've already signed up to ask patients not to enter if they have fever or rash. Quarantine can be very difficult, especially families over a 21-day period. And work for parents. Are there recommendations or a plan of how to handle this on a community level? As we learned in COVID, these people will show up to the emergency room and we hope to have.
Yeah, it's if there's all cases with fever and rash, and I'll say this and I'll ask Sarah to weigh into as well. We see this is not uncommon, right? We see this a lot. It's kind of like you or I, we see that this is kind of a common scenario. So all of those cases, they don't need airborne isolation, but it's suspect measles cases that do. So it's gathering that extra information, kind of decide, okay, well, maybe.
And if you don't have phone triage set up where you're gonna know what they're coming in with before, signage just saying, do you have a fever and a rash, put a mask on. It's a really simple way to just really reduce the chance that you're gonna have a mass exposure in your clinic. There's many of the things that do cause fever and rash are infectious, and it's not a bad thought for people to have at least a surgical mask on as they enter the room. That's gonna really minimize droplet spread.
Along the lines of mask, so we're going to ask patients to put on a mask. Typically, patients don't have N95s, but one of the questions was, I'm vaccinated, I have titer proof, why do I have to wear an N95 mask? This would be from the standpoint of the clinician.
Yeah, I can, it's 97% effective, so there is that 3%.
They have titer.
Yeah, so it's not, no vaccine is 100%. This is pretty close to it. It's an excellent vaccine, but we're healthcare providers. We take care of people that are very fragile and sick. And if we actually came down with measles after an exposure, it's 4 days before the rash onset. There could be that period where you're infectious and you may not know it, have symptoms, and you could pass it on to somebody. You could go to work, and 9 people out of 10 that aren't protected would come down with it, and that's not good. So we owe that to our patients. We take that little extra step, and it's not that we're talking about putting on an N95 mask. We've gone through COVID. We're pretty adept at being able to put on an N90. It's just an N95 mask. Put that on.
And I would just also add that there's a lot of other things besides measles that can cause fever, cough, and a rash. And since Since 2020, I know I, as a clinician, I do not see any patients without wearing a mask because I don't know what that patient might have. So even if the suspicion is measles, you don't know what kind of a viral infection they may have. And so that's why I really, maybe I just have trust issues, but that is why I pretty much always wear it with any patient encounter in person. I have a mask.
There was a question, and you did lay out a timeline, Sarah, but they said, is it ever too early to draw a PCR?
I guess too early would be somebody you don't suspect of measles. If you suspect, so even, for instance, this example does come up if we're investigating a case, right? You'll have an exposed contact who now develops a runny nose. Should you get a PCR on that contact? My answer would be if that contact could possibly have exposed anyone else if they had measles, then get that PCR immediately. Don't wait for the fever. So it's someone you're monitoring after a known exposure, get that PCR right away if you suspect a measles-related symptom. Don't wait for the rash. If you're just talking about someone coming into the clinic, I wouldn't be getting a PCR on everyone with cough, coryza, and even conjunctivitis necessarily. It really, you have to have the fever and the rash.
I'm gonna try to, it's hard for me to summate, so I'm just gonna read the question. One question had to do with the early vaccine that we give to infants between 6 months and 11 years old. 11 months old. And the question was along the lines of the long-term effects on building long-term immunity with given the early dose 0 at 6 to 11. Any thoughts? They seem to clearly understand that there will be the subsequent 2 afterwards.
Correct.
Advantages, disadvantages. Giving it.
So disadvantage? No, there's no disadvantage as long as the family understands it doesn't count and you've gotten good expectation management. The advantage is if there's not enough circulating maternal antibody in that baby and they go to a high-risk area, you have given that infant a solid chance at having immune protection from then contracting measles. So again, that's why we're not giving it to every baby 6 to 11 months old because we're not in an outbreak situation. It's only if you're going to enter a high-risk situation with that infant that you can't avoid. So there's no downside in terms of risk. The risk is that the baby doesn't respond to it because maternal antibody inactivates it. But in terms of then their long-term response to the 2 doses that are counted, there's absolutely no evidence that that dose 0 will interfere with that infant's ability to mount an appropriate and adequate long-term response to their 2 doses.
There are a couple of questions, and I'm just going to throw it out and let you answer it. Can you comment on risk stratifying travel? What truly is high-risk travel?
Take that one. So we don't necessarily want people to be giving lots of extra doses to anyone who's going to the mainland. I would look at where they are traveling to specifically. Right now, we're seeing large outbreaks in Texas, New Mexico, Kansas, Oklahoma. There may be smaller outbreaks in certain places. So you really do have to work with the traveler and look at where they're planning to go to. For international travel across the board, we're just saying, yes, do that early dose.
Thank you. All right, we have another one. And at some point, I'm watching for our time because there are just questions. This one is, we had a case in our emergency department. It was a child that was a little older than 8 years old. They had 2 MMR vaccines on schedule. Both IgM and IgG were positive. We were told by the DOH that this did not represent a true infection. They did not recommend PCR testing. Most of us were confused as to why the DOH did not consider this positive. And I don't know if this is a Hawai'i case or they have another experience. The child did not receive the MMR after 4 years of age.
Yeah, I am not familiar with a case
Yeah,
like
so
that.
I'm wondering if they're referring to a case that they just had experience with. It's not necessarily here, so now you're having to answer for a DOH issue on that. So if you don't have a answer.
I'm sorry, I might,
So this is Laura Rowland. And if you could clarify the case and put it in the question, maybe we'll come back to it.
sure.
Yeah, but when I first started reading it, I thought it was YBH.
I will comment that serologies can be very confusing. What was the age of this child again?
I think it was 8 years old.
8 years old
Yeah.
with prior known vaccine or no?
With known that.
Two vaccine doses.
On the schedule, so not recent. It does get complicated if there's been a recent administration of MMR. So if there's been MMR given in the last 8 weeks, there's a possibility that those serologies are just from the vaccine. And you really don't have a good way to distinguish between an actual measles infection versus having serology that's there, whether, and even if it's not the vaccine reaction, if we pass the time when you get a vaccine reaction, you might have some other cause of febrile rash, and now you have this conundrum. Those are probably the trickiest cases to work through, and I would definitely call DOH. We'll work through those with you. We've even gotten CDC consults on the line to help us sort those out. But often we have to make decisions based on the clinical circumstances, the epidemiology, and really what would be the risk of missing that as a case.
Yeah. I also think there are certain other viral conditions that can cause false positives with measles testing. And so it can be very complex and nuanced. And I mean, the good thing is here in the state, you're never more than a phone call away from somebody who can at least, kind of walk you through, talk you through the answer. So the right answer is always to contact the Department of Health before ordering necessary testing and stuff. Because again, in that case, if you have proof of 2 vaccine doses being given and you think the patient is acutely ill, only IgM and IgG titers kind of seem a bit odd and interesting in terms of the choice. So I think the best bet is when you suspect a case, please contact Department of Health before you go ordering things to kind of have them walk through it.
And I'll add in, and so just, I think that's a good reminder, like what both of what was said, especially with the cross reactivity. Remember to get that nasopharyngeal or oropharyngeal swab, which is much more specific. There's less likely to be that cross reactivity.
There's a number of questions that I think would probably just be answered by a reminder of where can everyone find the phone numbers and who to contact. I know it's in our slides, but I'd let you make that kind of combined announcement.
There's, as a general rule, if you call 808-586 for, I always reverse that number.
Got it here. So let's see the reading glasses. So for the 586 at 4586.
808-586-4586. That's the general number, but we do, as we put it in the slide deck, because there are local numbers for neighbor islands, and often neighbor island providers prefer to call through the DHO first for a familiar team there.
Thank you. There are more questions, but I think to respect everyone's time and also to realize there's been so much any group of people can absorb, and this has been, I think, information packed. Thank you to everybody. I want to thank everyone for joining us this evening, for the thoughtful time that you do and or the work that you do in the office every day, both in your clinics, the hospitals, and the community. I hope that tonight's discussion reinforced essential truths. And those are that measles is preventable, but prevention depends on readiness, and that's clinical, operational, as well as communicational. As clinicians, I think some of the key takeaways that you can carry forward would be confirm and document MMR status at every opportunity, whether in the clinic, urgent care, or during pre-travel consults. Immunity matters. Screen early and isolate fast. Measles spreads, as we said, spreads quickly, and time is critical to protect the staff as well as other patients. Report promptly and coordinate with the Department of Health. They're not just a resource, they are our partners. And finally, prepare your team and workflows now to prevent unnecessary exposures, especially when it comes to waiting rooms and shared clinical spaces. We're prepared to share with you all the resources presented tonight. They will be on the website for you to access both the recording of this, should you want to listen to it another time, or as I said before, the slides will be available. So you'll see a bit of a frequently asked questions of that covered quite a bit of the material that was covered today, testing guides, vaccine guidance, a little bit about the staff workflow or flow chart, I should say, and full contact and reporting information from the DOH. Our work isn't just about reacting to cases, it's about being ready when it arrives. Thank you again for your time, attention, and commitment to keeping the community safe. Good evening, everyone.